You guys,
All right.
I just came from a meeting with Edwin, so I'm sure he's coming soon, but he's continuing the discussion. I don't know if he plans to start, William, or we'll wait for him.
Actually, I don't think he will be presenting. It will be me. I just included his name because he some of the slides we prepared them together. Yep.
Perfect.
It's
Yeah.
good.
Oh, sorry for barging in then
We
without the information.
should be ready to go, William, if you're ready.
Yeah. Thank you. Thank you, everyone. So today I wanted us to have a discussion a little bit on some implementation science work, and of course talking about this determinant framework called the Consolidated Framework for Implementation Research. These slides we prepared them together with Edwin, so that's why his name is included here, just to acknowledge his contribution to this. But without further ado, I chose the CFIR framework for discussion because it's one of the commonest frameworks that has been quite used in a number of studies, and it's one of the frameworks that I think our group, the GEMINI group, is really used in a lot of its projects. So I believe this is going to be a discussion, and of course you are welcome to ask questions whenever you feel like, and you can interrupt me in the process. But anyway, I wanted to talk briefly about these few things to have a recap a little bit on some key implementation science concepts. I'm not sure about the cloud, of course. So I wanted us to remind ourselves of that, and then talk a little bit about why the CFIR framework and why is the framework like why CFIR, when should you choose CFIR? And of course, talk about some key components, and here I mean the domains and the constraints in the CFIR framework, and then touch a little bit about the outcome measure, which is called the CFIR outcome addendum, which is an implementation outcome measure, and I will have a few examples. So starting with in implementation science, I always have this very nice famous slide, which I like starting with it whenever I start with that. Implementation science, we always want to bridge the gap between what we know and what we really practice. And in doing this, we already have the intervention or evidence-based practice that has been proven to be effective, and we always call it the thing. We are trying to study and see the best ways of implementing it in order to reduce the knowledge gap. And then when we so effectiveness research looks at whether the thing works, and implementation, or sometimes it's called dissemination and implementation research, looks at how best to practice, how to help people best practice do the thing. So we are trying to really study on ways that we can bridge the gap between what we know and what we do. So that is dissemination and implementation research. So finding ways on how to best do the thing. So this is the focus of implementation research in science. And we always have the strategies of implementation, which are going to be the ways that help us do the thing. And we have our outcome measures, which are going to be telling us how much and how well we are really working in terms of implementing the thing. So these are very key concepts in implementation research. So we have the thing and doing the thing, and how well we are working. So I just wanted to have a refresher a little bit on this, and to make sure that everyone at least has an understanding of this. But as I mentioned earlier, implementation science is basically a discipline that really tries to study methods and strategies to promote, would it be the uptake or the adoption, the integration, and sustainability of evidence-based practices, all the things, so to speak, in the real-world setting, order to improve the outcome. So we are trying to study on ways to bridge the model gap, and this is very important. And so these are the key concepts in computer science. So this is a little bit of refresher in the field. So as I mentioned, there is always a lag here. So we have a lot of research, we have a lot of evidence-based research, but most of it is not really implemented in settings. Therefore, there's a gap between the norm. We call it the mind gap sometimes, or the norm gap. So implementation science is really trying to do studies which help us to prevent this. And sometimes, of course, there's a 17 years delay on implementation, generating the evidence and doing it more. So this sometimes can be attributed by several reasons. And these are some of the reasons that cause that explain why there is a gap between what we can do, why some interventions have been proven to be effective but yet they're not implemented. It could be explained by knowledge and attitudes in the community, that is population knowledge, attitude, practices. Sometimes there are several barriers like cultural or linguistic barriers can be some of the barriers that explain why we have a lengthened time between doing practicing evidence-based practice. So implementation science is aimed at really studying ways on dealing with these barriers and in the process, of course, reducing them. So now, in order to do that, we need to have, of course, a research question, as in any type of research. And after framing your implementation science question, you need to have a design way of thinking. And in order to do that, we always use frameworks. And there are different types of framework, and Nielsen taxonomy tries to explain the different pathways of the framework depending on the, of course, the research question or the implementation research question. So we broadly have three categories of frameworks, and we can have all mod, and these we call them theoretical approaches used in implementation science. So if you want to describe the process of translating research into practice, you can use process models or process frameworks. And if you just want to understand and all explain inferences, all implementation outcomes, if you want to understand determinants or inferences, I mean, to understand and all explain what inferences implementation outcome, you can have broadly three types of pathways. We can have determinant frameworks and classical theories and implementation outcome theories. And here we have a framework called the implementation outcome framework, or the Proctor framework. So if you want to evaluate implementation processes, you can have evaluation framework. So our focus today is on this arm, the middle one, and mainly we are looking at determinant frameworks. And CFIR framework is one of the determinant frameworks. So this is it's a pathway that helps us understand the trajectory in the implementation process. So it's the Nielsen taxonomy, and there are different types of frameworks in every aspect of it. For example, the process models, they have different types of them. There's the dynamic sustainability model, the FS. But for the determinant frameworks, we have a couple of them, and CFIR is a determinant framework. So here I wanted to highlight that CFIR framework is a determinant framework in the Nielsen taxonomy, and that's going to be our focus today. There are a bunch of other frameworks in different categories. So in implementation science, it's very important to use a framework. And the framework is going to be very important because it's going to help guide your thinking processes. So it's frameworks provide a guidance through the study process and the thinking process and the implementation. So they also help your research team they inform thinking to the research team. Therefore, they help you to have a common ground and a common understanding. They give you a three-dimension view of your study and experience. They also help in the interpretation of the finding. And so this is why frameworks are very important. So now we are going to today's concern. So the CFIR stands for Consolidated Framework. Consolidated, it means like many things are aggregated together. It's like consolidated. So it's a consolidated framework of implementation research. And it's a pragmatic or a practical, and it's a framework that has been created. So it's a determinant framework, of course, but it's a framework that is more pragmatic or more practical, and it's developed based on theory. So it's a pragmatic meta-theoretical framework. It's a study of theories. So there's a lot of theories which are covering behind the CFIR framework. But again, the CFIR framework is very novel. It's very new. The first CFIR framework was published, I think, in 2009, and so is the field of implementation research. It's still growing. So the CFIR framework, the first CFIR framework was published in 2009, and the latest update of the CFIR framework, I might be wrong about this, I'll have to double check, but I think it's in 2022 or 2029. So it's a really new framework. It's not old. It's not very old, I would say. But the CFIR framework, and because of this, there was a long systematic review that was done just to look at papers which had used the CFIR framework. And I think this review was done by Dan Schroeder. I think it was in 2019 or earlier. But by then, there were only roughly 128 studies which were identified to have used the CFIR framework. And I mean, these were people that used the framework, and the CFIR framework was used in different settings by then. So, for example, in healthcare, we had like 108 study. I think it was by 2019. I'll have to fact check this. General public health, we had like 5 published studies that were using the CFIR framework, and also in education and other fields. So the CFIR framework was used by these researchers in different aspects. Like some of the researchers reported to use the CFIR framework just to guide their data collection processes, because it's consolidated and guides different domains. I'm sorry if I may be having some background noises, but I believe you can hear me correctly. Right?
Yes, you're good.
Yeah, if you could just continue to speak loudly, that's perfect, William.
I should speak louder.
Just like that is perfect. Yep.
Oh, okay. So I was saying, so the CFIR framework has been used by different researchers in different aspects. Some researchers have used the CFIR framework to guide their data collection processes. It has helped them in guiding their analysis processes, helped them in interpretation. And you can see out of all these researches that were done, I think it was by 2019, this is how the CFIR framework has been used. But surprising enough, we have, by this time, I think when the study was done, only a few studies from low and middle income countries. I can recall where it was roughly 5 studies from low and middle income countries settings that had used the CFIR framework. So this framework was not quite used in low and middle income country settings. So this is a wake-up call for researchers, at least in the middle income country setting, to really try to use frameworks like this determinant framework in the research processes. So it's still a very new area that is not exploited. But again, before we dive into the science, I wanted to put this information to the audience. So people who use the CFIR framework were again asked, like, how do they find the framework? So there's what we call the Flotop's criteria for letting, which really tries to understand how different researchers perceive a certain method. So these scientists were asked about how did they find the CFIR framework to be applicable in their how did they find to be in terms of simplicity? Was it simple to use? Because one of the key things that people complain a lot based on the literature that I've seen is that implementation science frameworks are very complex to understand, they're difficult, and therefore, so this they wanted to tell us, like for the CFIR users, how did they find it? Was it applicable? Was it simple? Was it logic? Was it user friendly? So you can see clearly that of the people that were 128 who were given this survey, they close to 86% of them, which is 86 of them, which is 67.2% of them, found that the CFIR framework was applicable for their setting. I mean, across different settings. Again, applicability of the CFIR framework for different type of innovation was found to be like 81.3% of the participants found the CFIR framework. The bad news is that only 15.7% found that the CFIR framework was not simple, so it was complex. And this is because maybe we'll see later on that the CFIR framework includes a lot of domains in it, but it's not always necessary to use all the domains in the CFIR framework. It's important to have that, but it's not important. So people were saying that the CFIR framework is not simple to use, and of course, if you look at other aspects like usability, easy for non-implementation research to use, of course, this is expected. So for people who don't know implementation research, don't know implementation science, it's not quite easy to use. So you need to have like some background information on implementation science. So this is just to tell you how other people perceive the CFIR framework. Now, so the CFIR framework is a structured and it's a really organized framework. It addresses multiple levels. So it's kind of complex in that area. And we'll see like there are different levels where the CFIR framework really, there are different, I mean, construct of different levels, and that makes it some of the CFIR framework to be complex. But it's really flexible, and it's flexible because sometimes it includes constructs from a synthesis of existing theories, and therefore it makes it a little bit flexible for tailoring, but it's really complex because it includes a lot of domains. So speaking of the CFIR framework, it broadly has 5 domains and 48 constructs. So every domain has some areas that needs you to focus. For example, we have the intervention domain, we have the inner setting domain, we have the outer setting domain, we have the individual or the individual characteristics domain, and we have the process domain. So these are the 5 key domains of the CFIR framework, and they are depicted here. So this is the first illustration of the CFIR framework where you see like you have the individuals involved or the individuals who are going to receive the intervention. Then you have the setting where these individuals are present. Then you have, which is the inner setting. Then you have the outer setting, and then you have the processes. So these are the 5 domains, but each domain has what we call the constructs. And in total, we have like 48 constructs. I think that is for the updated CFIR framework. So that makes the CFIR framework a little bit more complex because of having too many constructs. So this is the CFIR. So we'll see each domain separately, but in the intervention domain, which is the intervention characteristics, you want to, because implementation science is really tailored around trying to have an evidence-based intervention. It can be a policy, it can be a program that has been proven to work, and now you're trying to study it. So the intervention characteristics in the intervention domain, you look at, and the constructs which are present in this domain are these ones. You look at the source of the intervention, you look at the triability, can the intervention be tried in that specific setting, in that specific context? Is there evidence of strengths of that intervention? And what is the relative advantage? What is the adaptability? What is the cost of the intervention? So these are the things that you want to study when you're studying the intervention. When you are speaking the intervention characteristics. So what is the complexity of the intervention in that setting? Okay, but every construct doesn't have to be studied, but these are very important to be taken on board when you're considering the intervention characteristics. So then we have the inner setting, and we'll see an example. I have an example close to the end. So, and when you're speaking about the inner setting and the outer setting domain, you really want to understand the setting. The inner setting is going to be where the intervention is going to be implemented. And the outer settings are going to be the surroundings around your inner setting. So, so the inner setting is going to be so you want to understand, so you want to understand these settings in particular. You want to acknowledge and account for the economic, political, and social context, especially these are going to be mainly the outer setting. So within which we call it the outer setting, is going to affect your implementation processes, and through which is the inner setting, is really going to also depict your implementation process. So you need to really have a clear specification of the inner and the outer setting. And we'll see. So this is again a reminder on the key domains. So for the outer setting, so you want to look at patient needs and resources. When it comes to the outer setting, you want to look at cosmopolitanism, which is also important, and you also want to look at the influence of other factors like peer pressure around your intervention and different external policies and incentives that can really affect your intervention. And in the inner setting, these are some of the constructs in the outer setting domains. There are more to this list. But in the inner setting constructs, you have these, the inner setting domain, these are some of the constructs which are present. You want to make sure that you understand the structural characteristics of your inner setting. You want to make sure that you want to understand the networks and communication around your inner setting, the culture. Maybe culture might be one of the barriers towards implementation, towards adoption, towards acceptability maybe of your intervention. So you want to make sure that you also study that. So you also want to look at the implementation climate in a setting. And this is very important. You want to study the attention for change. Are there any compatibility factors? What is the relative priority? Organization incentives, and also you want to understand goals and feedbacks and the learning climate as part of your implementation climate. Also, in the inner setting, you have to look at readiness of your inner setting. Like, are leaders really ready to engage? What are the available resources and what are the access to information and knowledge? So these are the constraints present in the inner setting. So when it comes to individual characteristics, so in this domain, you want to recognize that an organization setting is comprised of an individual who are the really end users of any intervention. So these individuals, there are different individual factors which can influence the organizational outcomes. So you really want to understand the knowledge and belief of the individuals about the intervention. Also, you want to look at any evidence of self-efficacy around the individuals and the stages for change, and also identification of individuals within the organization. So these are the constructs present in the domain. For the individual characteristics domain. So for the process domain in the CFIR, here you look at, so you look at the essential activities of an implementation process. And what is involved here is virtually planning. And here you want to engage different champions, implementation champions, because they are going to be very important for your implementation process and the uptake of implementation. So we want to involve champions like leaders and other important policymakers and stakeholders. These are going to be very important in helping you execute the implementation process. Okay, so yeah, that was in a nutshell a little bit around the tour around the domain, the CFIR. So the 5 domains and some of the constructs which are present. I'll skip this for now. So I want us to go through one of the projects that used the CFIR framework, and this is going to be one of the grants I think Edwin participated in writing. There's and some of the team members here. So it's called the Protect Our CPG adaptation of KSMC. So this was an R21 which was written by the team, and they wanted to use the CFIR framework in viewing this problem. So the problem is that right now we know that the world is aging, and it's projected that by 2050 the number of adults who are aged 60 years and above will double, and with sub-Saharan Africa is expected to experience the fastest growth rate of the aging population. When it comes to trauma and injury in Tanzania, approximately 6% of the population is over 60 years, and 1 in 10 trauma patients is an older patient in the country. So with the increasing rate of an aging population, that means we might have more cases of older people who are presenting with trauma. So again, there's a higher mortality rate where we see 30% of mortality rate for patients who are coming in with trauma, older patients, which when compared to younger patients is close to 10%. And when you look at older patients, like the length of hospital stay for older patients is longer compared to younger patients, where you see like older patients have at least 9 days less of hospital stays compared to 4 days for younger adults. So not only do we have a growing population, not only do we have an increase in an aging population, an increase and a possible increase in trauma burden among this aging population and high mortality rate, these older people are having also a longer length of stay. And the financial burden among this older population is much higher, whereby approximately 80% of elderly people pay out of pockets, with costs twice the median monthly income. So they're not earning more, especially at this age. So 20% of families go into debt or sales assets to cover medical costs. So this is a real problem that was identified for this project. So now there is an intervention for the clinical practice guidelines that have been are very important when it comes to older patients. And high-income countries have clinical practice guidelines to really take care for the elderly population. So centralizing all the other trauma care in tertiary facilities reduces mortality by 20% if they have good clinical practice guidelines. And this is basically because clinical practice guidelines are involving the use of evidence-based protocols, and therefore this can lower mortality and complications by 4%. And the American College of Surgeons, CPG, improved specialized consultations and multidisciplinary. So clinical practice guidelines are very important when it comes to management of patients who are elderly. But within low and middle income countries setting, there is no existing older adult trauma clinical practice guideline tailored for low and middle income countries setting in our country. Therefore, adapting a high income countries based clinical practice guideline requires context specific modification. So this is to say that we need to have a CPG or clinical practice guideline that is meant to help clinicians in taking care of patients who are older, who are presenting to the emergency department with injury, and we don't have a guidelines for our setting. So maybe adapting a guideline from high-income country setting, tailoring it to be context-specific might be beneficial. And this brought to the need that there's a need for a CPG, especially for KSMC, because KSMC is the third largest tertiary hospital in the country, serving at least 15 million people in the northern part and elsewhere. And it receives roughly 2,000 injury patients annually, and 13% of whom are older adults. Therefore, there is a need for having a clinical practice guideline specifically tailored for the elderly population. And therefore, the Protect Toise project was the solution to this, because it aims at really creating a patient-centric approach to adopt and implement an older adult trauma clinical practice guideline at KSMC, and therefore involving patients, healthcare providers, and families to ensure cultural appropriateness. This is very important. So in the development of the CPG, these are the key identified champions. And this can be built on successful contextual CPG adaptation previously deployed by our team. And here I have to highlight that our team has successfully created a clinical practice guideline which was specific for traumatic brain and injury patients. Therefore, building from that experience, this can be done similar to the elderly population, creating a guideline that is specific to them. Now, this is where the study had two main aims. I think the first aim was to identify the barriers to implementing an evidence-based clinical practice guideline for older adult trauma patients who are presenting. And this was going to be done quantitatively and qualitatively. Quantitative part was going to determine what is the drivers of poor outcomes, or what are the predictors, what are the determinants, and this was going to be done by using the secondary analysis. And the estimated sample size here was close to 400 elderly patients. And then the qualitative phase for this aim was going to explore the barriers or the determinants and needs to the older adult trauma care system. And here, this is where we chip in today that we wanted to use the Consolidated Framework for Implementation Research 2.0, which is the second version of the CFIR that I think was developed in 2019. So now, in order to do this second part of the aim, which, as I mentioned here, that we're going to use the CFIR framework. This is how the CFIR framework was structured to use by using the 5 domains. So we have the domain, the outer setting domain, the inner setting domain, the innovation itself, which is the CPG. So our innovation, our innovation, all our evidence-based practice, all the thing in this regard was going to be the clinical practice guideline. And therefore it's going to be important to know the source of this guideline. Where are we going to get it from? Are we going to adapt it? And what are the processes? So what is the adaptability of this CPG in KSMC context? What is the relative advantage using the CPG? And what is it a complex CPG that clinicians cannot really use? And what is the cost of implementing the CPG at the KSMC setting? So this is what the project and this is how the CFIR framework, they wanted to understand this domain. And then the outer settings, which was going to, because the CPG was going to be implemented in the emergency department of KSMC. So the inner setting was going to be the emergency department. And it was very important to look at the culture in the emergency department. What do they routinely do when they see 67 years old female presenting with a fall? So what is the common practice in the inner setting? What is the network and communication scaled at the inner setting? What is the possible acceptability of the healthcare providers to get into CPG? Will they accept it? They won't accept it. Why? If they will, why? And so there was going to be a mixed, like this can be done quantitatively or quantitatively, and what are the available resources that can maybe be barriers to really hinder the adoption of the CPG? Do we have enough healthcare providers at the emergency department? Do we have enough screening tools for elderly? And this is actually going to be based on how the CPG works, right? So are there any organization and incentive rewards that are given to healthcare providers that can really help them or can motivate them to really use the CPD and their access to and knowledge and information about the importance of clinical practice, of using clinical practice guidelines for this elder population. So the outer setting was going to be the KSMC environment other than the emergency department. So it was important to be important here to study what are the local attitudes and beliefs, the conditions, partnership connection, policies and laws outside the inner setting, and what are the external financing and of course, the hospital readiness to make sure that the intervention is in place. So when it comes to the individuals, and these are going to be the implementers now of the CPG, which we are going to be the EMD professionals or emergency department, healthcare providers, and the patients, of course. So the needs, the capability, the opportunities, and what are the key motivators that can help these individuals really adapt the intervention. And then again, it comes the processes now, making sure that the implementation, I mean the innovation or the intervention is in place, like what are the planning process, engaging stakeholders, because I think it's important to really identify who you need to engage in order for your innovation to work, and what are the strategies that you're going to use to make sure that the innovation, which has been proven to work in other countries, to reduce the mortality and the morbidity among the elderly population. What are the strategies? What are the implementation strategies? Are you going to train these healthcare providers? Are you going to are you going to train them as one of the strategies? So that was going to be the process part, and then so this is how the CFIR framework has been projected to be used in this project. Now, when you have something like this, you need to have your outcome measures, and we call them the implementation outcome measures. And the good news about the CFIR framework is that we have what we call the CFIR outcome addendum. So an addendum is a combination of different outcome measures from different frameworks. So the CFIR outcome addendum is a combination of outcome measures from different frameworks. So they use the Lee-Aim framework. So we have some of the Lee-Aim outcomes here. We also have some of the Proctor's outcome. We call them implementation outcome measures. And we also have that. So you need to have your implementation outcome on board whenever you're having your implementation science question. So you need to have your outcome assessment. So the CFIR outcome addendum, it's published. I think I'll share the link. But whenever you're assessing outcomes for an implementation science project where you've used the CFIR framework, there are certain key areas. So the implementation outcome is divided into implementation outcome and innovation outcome. When you are speaking about the implementation outcome, we have anticipated implementation outcome, and we have actual implementation outcome. So the anticipated implementation outcomes are going to be indicators of anticipated implementation success rate. In other words, we have our CPG in place in the emergency department. How are we going to, what do we anticipate, like expect in other words? So adoptability of the CPG, implementability of the CPG, and sustainability, which, for example, the EAM framework is called maintenance. There are different principles. So in the CFIR, they prefer to use sustainability rather than maintenance. So these are going to be the anticipated. So before you have put your intervention in place, before, for example, the CPG is in place, we have to think around these outcomes. What is the adoptability? And by adoptability, I mean, like, what will be the active? The implementability is like, can this be implemented in the emergency department setting? Will it? How can I sustain the CPG? For example, when the group was developing the CPG for TBI, it trained the physician and then they left for a while. So the sustainability, what are the sustainability plans? So you have to have sustainability as one of your anticipated outcomes. And the actual outcomes are going to be your indicator measures of implementation success. So when now you have actually started implementing your CPG, for example, what is the adoption? How many clinicians are using the CPG? Are they implementing and the sustainment? So these are what are called the actual outcomes. And then we have what we call antecedent assessment. So if you read what the proctor's outcome, we have acceptability as an outcome. Appropriateness. Acceptability is if, for example, the clinicians in the emergency department will accept the intervention. Will it be appropriate for the setting? Will it be feasible? What about the implementation of outcome? So these antecedent assessments in the CFIR outcome addendum, they can project anticipated and actual outcome. Therefore, they don't really include them as implementation outcomes when it comes to the CFIR outcome addendum, because the acceptability, for example, can predict adoptability of the intervention. Appropriateness can really predict implementability of the intervention. Therefore, when you read the CFIR outcome addendum manual, they say that these antecedent assessment outcome measures really can predict implementation outcome measures, like they can predict anticipated outcomes and actual outcomes. And therefore, they don't really include them as implementation outcomes when you're using the CFIR outcome addendum. And then you have innovation outcomes, of course. These are going to be the indicators of innovation success or its failure, where you look at the deliverers of the intervention, the key decision makers, their perspective, and their innovation response. So this is very important to tie. And of course, if you can look at up top here in the CFIR implementation determinants, so when you have your determinants like the barriers and facilitators, you can really link them together. So it's really important to think around implementation outcome. And the good thing about this outcome, we have this addendum which can help you really assess your implementation process in the process. So I wanted to touch base on this before I move forward further. Yeah, so that's it for the Protect to Azure project and how the CFIR framework was really used in the thinking process. And therefore, this has simplified the work. Can appreciate that. Yeah. So we have another example, and this is a study which was done also in the emergency department at KSMC, and this is the team that did this study. And they really, the study was around myocardial infarction. You can check this online. The title of the study was Improving Acute Myocardial Infarction Care in Northern Tanzania, Barrier Identification and Implementation Strategy Mapping. So they use the CFIR framework to really study this. And so in the CFIR domain, for example, the innovation, the construct for complexity. So this is going to be a study with results. So these are the key barriers. So they wanted to identify barriers to improving cardiac infarction, because in the emergency department at KSMC, so this is what they identified as barriers from the innovation domain, providing timely and evidence-based cardiac infarction care will require substantial changes to current emergency department opportunities, and this is the number of providers who responded to this. So they reported the results based on domains. So innovation, it was postful, like to have a high quality of manufacturing care requirements, extension for the hospitals, on and on. And the inner system, they imported the domain, they imported this construct culture. So there was a culture barrier in really implementing care. So more and more barriers per construct. I won't go through this so that we can have time to discuss. But after you have identified your barriers and facilitators, so we have what we call, the good thing about the CFIR framework, we have what we call the CFIR ELIC tool. It can help you to identify the implementation strategy, and it can rank them based on their importance. So the good thing about the CFIR framework is that we have that the CFIR ELIC tool, which can really help you to identify the implementation strategy along the intervention. I think that was it from me. Yeah, thank you for listening. Now I welcome more expertise. You know, we have CFIR champions here. Asante, back to you, Joe.
And this was a great presentation, William. Thank you so much.
Yep.
Can you tell us something before people, of course, are getting ready to ask questions, but also can you tell us a little bit about your interest for implementation science? I know that you're doing the fellowship, right? If you can tell us about how it's been your process of learning, how it's been your process of applying population science in your projects, just so we get a sense of your way around it.
So yeah, I'm still learning, as you can see, and I think we have the support from the team. Like doing this presentation is part of the learning process. So I think it's going smooth. I think it's going smooth,
Okay.
and I'm thinking of writing more projects with an implementation science focus, and yeah. So yep.
Sounds good. Great.
Yeah.
Anyone in the audience that might be interested in doing a project with implementation science that might have questions, or anyone that has already attempted or is planning to do, if you have any questions, I'm sure that William is going to be more open to respond.
I've been taking notes on some of the examples that you shared. I'm working with Catherine on a implementation science project in Moshi, Tanzania as well with KCMC. If you have a few other examples of projects or papers that have been published that have used the CFIR framework, that would be awesome for me to just have an example of kind of what the final product might look like. So I just looked up the one that you just shared about myocardial infarction. If you have a few other examples that you could share in the chat, that'd be super helpful to me.
Yeah, sure. Let me pull them up. Thank you for that.
Yeah, and thank you. This was great.
There are these resources that have been shared by I think Ashley. Those are they're very useful sites in learning the CFIR, and they really give a history on the genesis of CFIR and then what is currently thought about the CFIR. So I think those will be useful. Just look and see if I can share more in the chat, or I will add them to the spreadsheet. Yeah.
Cool. We can send an email to the folks at the listserv as well afterwards with the extra references.
Okay, sounds good.
That'd be great. Thank you.
Mac, I just put in the chat the link to the official CFIR guide website. I don't know if that was shared before, but they have a tab that links you to PubMed that uses all that links you to all articles basically that use the CFIR framework. This is still the older version, so the CFIR original, not the CFIR 2.0. But that might be a useful starting point to kind of filter through, see what's there.
That is exactly what I'm looking for. Thank you.
Yeah, thanks, Anna, for that. Yep.
Yeah, William, that was a great presentation. I think you really managed to make it practical and applicable and help us think through, you know, when you have a problem, an implementation science problem, how can you use a framework like this? Because I agree, it seems really overwhelming with all the different constructs and all that kind of stuff. So congratulations, that was really good. While I was just sharing the website link, it's also helpful to really think through, you know, how am I going to answer these questions? Is it a qualitative approach? Is it a quantitative approach? Who do I need to talk to? And kind of what you were saying, right? Thinking through what resources are already available and what have others done can be super helpful. Because most of the times we don't need to reinvent the wheel, right? Chances are there is a study guide or an interview guide out there or a survey that try to assess a certain construct, for example, of the CFIR. So well done, kind of giving those practical applications. That's great.
Yeah, thank you, Anna, for that. Yeah, it's really, I take your point, like, it's really not reinventing the wheel. It's gonna be very hard if you, especially when you're dealing with these frameworks. And the frameworks really they give you a think through process. Like they give you, like, I think if you look at the website, they give you even a guide. I think there's even a tool that can tell you like what questions to ask in which construct specifically. But as you mentioned, Anna, it's really overwhelming, and there's a lot. For example, we have 5 domains with 48 contracts in the 2.0 version. So that's a lot of things. It's a lot of checklists. And therefore, it's very important to tailor every domain and every construct based on your research question, based on how you want to frame your question and how you want to approach it. Yeah, I think that's very important, and that's very relevant when it comes to not only the CFIR framework, but to also some of the implementation science framework based on the medicines. So I think that's very well said, Anna. Yeah. And again, Anna, you mentioned something around your approach. I think that I didn't touch about that part, the study design around the CFIR framework. So you can have a mix of qualitative work and quantitative work in assessment of like as you're approaching when you are using the CFIR framework. And really, you can have measures, implementation outcome measures. We have what we call the IM. We have different outcome measures because we have implementation outcomes, like I showed in the CFIR outcome addendum, but you really can have outcome measures which are very specific. Like how can you, for example, measure acceptability? How can you, for example, measure adoption? Will you look at the number? So I really didn't touch about the approach of the study design that you can use, but it's really a mix of quantity and qualitative work when you are designing a civil. So I think that is very important. Also to mention, yeah.
Yeah, I agree with you, William. I wonder too, I know we're at time, so maybe that's for another discussion or conversation, but especially in implementation science, right? There's always the time component. We always want to be as efficient as possible and to get the information that we need to make quick changes, right? So thinking about the study design early on can really help to be efficient in terms of how are we collecting the data and how are we using that. So and I think that's hard, right? Because sometimes we feel like we need to answer all these questions, that maybe we only need to answer one of the questions.
Yeah.
All right. It was a great discussion. Thank you again, William, for leading this. We're going to have the recording online. So if you want to revisit and go through the material again, please do and share with your colleagues, with your network. But otherwise, we're going to see each other next week. Thank you all for coming.
Thank you. Ciao, ciao.
Thank you. Bye.